All right. Okay, good afternoon, everybody. My name is Frank Chalet. I'm past president and member of the board of directors of the Parkinson's Resource Center. On behalf of the PRC, as we call it, of Spokane, where our mission is to educate and empower individuals with knowledge to improve your ability to address Parkinson's and improve your quality of life. And also our partners, Northwest Parkinson's out of Seattle. I'd like to welcome all of you here today to our September 10th telehealth. And also I'd like to welcome all the many outlying communities for joining us for today's program. As always, I'd like to thank Northwest Telehealth for producing today's program. Tim Braun and Keith Carlisle are here supporting us today. Thank you, gentlemen, as always, for that. And our host, St. Luke's Rehabilitation Center, for supporting us here every month when we host it out of Spokane. Also, our sponsors, Albertsons, and our PRC Board of Directors and staff, including Cindy Cook, who is our great supporter in the back, for being here today and making this happen. And of course, all of you at our sites for your generous support and support of telehealth. And I'd also like to throw out a special note of thanks and appreciation, especially the estate of Viola Ewell, for her contributions to the education process. And so we're very thankful to have her contributions, as well as all the others who have made this happen month in and month out. And lastly, and of course not least, all our volunteers throughout the area for making this happen, and especially Jackie Ewell, our volunteer coordinator. So as always, as you folks know, our protocol is hold the questions till the end. At that time, of course, I'll call on each site to ask any questions that you might have, including our host site here in Spokane. And please do write down your questions if you can in advance of the program so we can be efficient. And also, remote sites, please do mute your microphones rather until we get to the Q&A session. And we will, as we've done it in the last few months, take attendance when we call on you for the Q&A. So without further ado, it gives me great pleasure to announce today's speaker. Dr. Bill Britt, Jr. is a practicing neurologist in Spokane, and he also is the medical director of the Holy Family Stroke Program, which is an inpatient hospital program. His background as a board-certified neurologist and also focuses on movement disorders and degenerative diseases of the brain, such as things like Alzheimer's. He's has an outstanding education from the University of Texas Medical Branch at Galveston, with his residency and fellowship training at Baylor College of Medicine. Today's topic that Dr. Britt is going to discuss is preclinical symptoms and early clinical signs of Parkinson's disease. So please join me in welcoming Dr. Bill Britt.
Well, thank you. I'll try to remember to stay in place and to speak up. Is the volume okay with how I'm speaking? Okay.
We're hearing you fine out here.
Is the volume better now? Let's see if we can't do that. Anyway, I want to thank the organizers for inviting me back, and feel honored to be here. I've not given any kind of presentation on the subject of the preclinical symptoms or manifestations of idiopathic Parkinson's disease before, so we'll see how I do with this topic. And I will have to apologize to the group. A few weeks ago, I was notified that I'd agreed to give a presentation at the Resource Center and was asked, what's my topic? Well, I had in the back of my mind that I wanted to review information about, the current thinking about the preclinical state in Parkinson's disease. And so I gave this title, and it got on and got announced and so on. And then I remembered that I forgot to check the list of titles of presentations that have been given on this education series recently. So I'm hoping this is not a redundant topic for you, that this topic hasn't been reviewed recently. If it has, perhaps I'll give a somewhat different take on it for you. Preclinical may not be a particularly familiar term to most of you, and I want to focus first on that with the example of Alzheimer's disease. Alzheimer's disease is also a neurodegenerative disease. That term neurodegenerative means that the disease occurs because of damage in the nervous system from nerve cells that get sick and die due to things intrinsically wrong in these nerve cells. In other words, it is not due to stroke, where there's inadequate blood flow to the tissues, or inflammation, where nerve tissue is damaged by infection or inflammation and multiple sclerosis. It is due to intrinsic disturbance within the nerve cells themselves. And for individuals with Alzheimer's disease, about 10% have a strong family history of Alzheimer's disease. They will have multiple relatives in successive and in their own generation being affected. Of that group referred to as having familial Alzheimer's disease, the very large majority have what's referred to as late onset Alzheimer's disease, meaning the disease begins at age 60 or later. That term came about when we used to think age 60 was old, I believe. But only a very small percentage have what's referred to as early onset Alzheimer's disease. And that is a group of genetic disturbances in which a single gene is defective. In patients with late onset familial Alzheimer's disease, there has not been found any single gene disturbance to be responsible, but a genetic pool of disturbances is present that increases the risk for the development of Alzheimer's disease. In the individuals with early onset familial Alzheimer's disease, if a parent is affected, in general, the risk for inheritance of the disease is 50%. And the disease manifestations typically begin when the individuals are in their 30s or 40s. The earliest, or let me rephrase that, the youngest patient diagnosed with Alzheimer's disease was age 18 at the time of diagnosis. Now, the science of Alzheimer's disease and of neurodegeneration has been aided greatly by these gene disturbances, because some have been put into animal models. So there are mouse models of early onset familial Alzheimer's disease, and these animals develop the pathology in their brains that occurs in the brains of the humans from which those genes were taken. And it is feasible to study them and to study treatments for them, including, what we're most excited about is therapies that remove amyloid from the brain in patients with Alzheimer's disease. Amyloid's the protein that is deposited abnormally in Alzheimer's disease that leads to nerve cell loss. So with that background about Alzheimer's disease, what I'd like to point out is that we have additional and new information that confirms what had been known from other ways of studying the disease process, which is that in Alzheimer's disease, the pathological changes in the brain that lead to dementia have been developing for decades. And these individuals with early onset familial Alzheimer's disease have been studied now in ways that look at the amount of amyloid deposited in the brain and subsequent changes in the spinal fluid concentrations of amyloid and tau protein that indicate that the disease process in these individuals has been going on for decades. So if we assume that our patient who was diagnosed with dementia of the Alzheimer's type at age 18 had a specific gene disturbance for the development of Alzheimer's disease, the neuropathological changes and tissue damage must have started, at birth or even perhaps before. So neurodegeneration in Alzheimer's disease is a process that has a very long time course. Now, when someone is developing Alzheimer's disease, the very large majority, develop disturbance of memory, of recent recall and memory function, and have a memory disorder long before they get other impairments of daily functions and cognitive manifestations that are characterized as dementia. Now, a memory disorder is a condition in which there is a disturbance of memory that is more severe than what's normal for age-related memory decline. So as we age, and particularly when we get into our 60s, we begin having difficulty recalling names of places, what did I come in here for kind of experience. We tend to misplace things, so on. That's an age-related memory decline, and that progresses with aging such that the normal individual at age 85 has substantial and testable impairment of memory performance. And the distinction between memory disorder and dementia is that dementia is the term that's used when in people with Alzheimer's disease who have a history of a memory disorder and then began to have other changes in nervous system function that impair daily activities. They are impaired dressing, driving, using tools and appliances, and ultimately bathing, feeding themselves, and so on. Now, the best way to think of this term preclinical is that when an individual develops dementia and the testing indicates and the history is consistent with underlying Alzheimer's disease, they're said to have dementia of the Alzheimer's type. And the preclinical manifestations of dementia of the Alzheimer's type have been a memory disorder, particularly for recent recall that has been present for some years. So in the case of Alzheimer's disease, memory disorder called mild cognitive impairment, that's the current term for a disturbance of memory function that's more severe than what's normal for age-related memory decline, has been present. Well, as you might guess from the title, there are also frequent preclinical symptoms of Parkinson's disease. The old concept of Parkinson's disease was that it was a movement disorder. And it was characterized by the triad of symptoms that Dr. Parkinson so elegantly described of rest tremor, tremor referring to movements that have an oscillatory nature rather than jerks and twitches and whatever, ticks. And a rest tremor is a tremor that occurs when a limb or body part is not being moved actively. So in individuals with Parkinson's disease, rest tremor commonly begins in the forearm and hand and when the individual is sitting with the hand in his lap or walking with the hand at the side, the tremor is seen. And when that individual moves moves the limb, and we test that by positional changes and dexterous movements, the tremor subsides, at least when it is mild. Slowness of movement, or 19th century term, bradykinesia, we have a lot of 19th century terms in neurology, refers to the reduced speed of activities, not only for walking, for example, or transitioning from a seated to a standing position or in and out of bed, but also to an overall decline in movement. So if I ask somebody with Parkinson's, who's newly diagnosed with Parkinson's disease, tell me how long it takes you to get up in the mornings and get dressed and shaved and get down to the kitchen for breakfast, and how does that compare to what it was like 5 years ago? And there's a huge change in speed there. In Parkinson's disease, there's also rigidity of muscles, and it is referred to as cogwheeling rigidity, because when the tense muscles are moved passively, the increased tone has a ratchety quality to it. That is the cogwheel, present in limb muscles and in muscles of the spine, particularly of the extensors of the neck. Now, in the last couple of decades, a fourth characteristic feature of the movement disorder has been added. So we refer to postural instability, which tends to happen with advanced disease, that is not typically present in Parkinson's disease for many years. And postural instability refers to an impairment of standing and walking balance and equilibrium, hence risk for falls. Now, that's the old concept of Parkinson's disease. It's purely a movement disorder. But the onset of the characteristic movement disorder establishes the diagnosis of idiopathic Parkinson's disease. So that is when the clinical manifestations of Parkinson's disease, the overt signs and symptoms of the underlying disturbance in the nervous system, can be established.
We don't always run in this order. You can get one of those and then another one.
That's correct. That's correct, and I'll amplify that in just a minute. Now, our current understanding of Parkinson's disease is that it is a neurodegenerative disease. So as described, there are sick neurons within the brain that are dying prematurely due to intrinsic disturbances in the cellular functions. And this neurodegenerative disease is characterized by certain symptoms common prior to the disturbance of movement developing, and with the subsequent appearance of autonomic dysfunction, and I'm going to talk about that more, but the autonomic nervous system is affected, neuropsychiatric symptoms, and cognitive impairment. And I'll speak about each one of those individually. The diagnosis of idiopathic Parkinson's disease is made by physical examination. That is, we as yet have no test specific for Parkinson's disease, although we are getting closer. But the characteristic movement disorder that I described with that tetrad of symptoms that may be present, usually the presence of 2 of the 3 symptoms is considered sufficient for diagnosis. And it is necessary to eliminate other causes of Parkinsonism, stiffness, slowness, perhaps tremor, such as drug-induced Parkinsonism. Now, that is not recreational drug-induced. This is medical or pharmacologic drug-induced Parkinsonism by medications that have been used chiefly for the treatment of schizophrenia or of intestinal disturbances, so that either antipsychotic medications or the medication metoclopramide, the trade name is Reglan, have caused Parkinsonism, not because they damage the nerve cells that produce dopamine. That's the dopamine deficiency in the brain that leads to the movement disorder, but rather because those drugs block the receptor that dopamine has to activate to get the desired effect. So that the drug-induced Parkinsonism results from an impairment of receptor function, not any damage to the nerve cells themselves. And in most cases, the Parkinsonism subsides fully when the offending medications are withdrawn. It's also necessary to eliminate related disorders. I like that term. If you go to a university clinic where a large number of people with Parkinson's disease are treated, the clinic will usually be titled Center for Parkinson's Disease and Related Disorders. And within that clinic, about 3/4 of the patients will have idiopathic or typical Parkinson's disease, and about 1/4 will have related disorders, which typically are more severe. They involve broader areas of the brain. These related disorders typically respond poorly, if at all, to medicines for the Parkinsonism that usually help people with idiopathic Parkinson's disease. And these related disorders have a much worse prognosis for survival and for disability. The common ones called Parkinson's plus syndromes are PSP, that's progressive supranuclear palsy, and MSA, that's multiple system atrophy. And both disorders do affect same areas of the brain affected in Parkinson's disease, but also other areas. One of the ways of eliminating those disorders is with imaging of the brain. Certainly the history and physical examination are helpful, but there may be specific imaging characteristics, for example, MRI changes in people with PSP or MSA that are not seen in Parkinson's disease. So when you present to the doctor with symptoms of Parkinson's disease and he orders an MRI, he's not doing that to confirm the diagnosis of idiopathic Parkinson's disease, but rather to eliminate some related causes. Vascular Parkinsonism also is apparent on imaging, and that refers to the individuals who have had multiple, usually small, strokes from vascular disease, atherosclerosis in the circulation to the brain, impaired flow, and damage to the brain, multiple small strokes, especially in the deep frontal areas of the brain. And these people will have a Parkinson's-like walking disturbance and balance disturbance, will have increased tone in muscles of the legs, but seldom get tremor or much in the way of manifestations above the waist. An early term for vascular Parkinsonism was lower half Parkinsonism, because if you just saw the lower half of them walking, you think that patient surely has Parkinson's disease, but it's vascular Parkinsonism. And another condition called normal pressure hydrocephalus. Hydrocephalus is a condition in which the sacs within the brain where the spinal fluid is formed become extremely enlarged because there's an impairment of the spinal fluid reabsorption, and yet the spinal fluid continues to be made. The normal pressure refers to the fact that the brain shrinks or atrophies as the ventricles enlarge, and the pressure in the head does not get increased from the increased volume of fluid. But these individuals have a severe gait impairment. They usually have trouble initiating walking. They may have freezing, much like people with advanced Parkinson's disease may have. And they have cognitive impairments, not just memory disorder, but more severe cognitive impairments. They typically have difficulty with continence of the bladder. And they're often impaired by a slow speed of mental processing. That is, if I ask someone with normal pressure hydrocephalus a question, simple question, who do you live with? There are a couple of beats, and then the response comes forward. So those would be important causes to eliminate and add further confirmation to the diagnosis of idiopathic Parkinson's disease. Now, the characteristic movement disorder, only about 2/3 of people with idiopathic Parkinson's disease have a tremor. And interestingly, that is present in the people who do have tremor, usually right at the onset of the movement disorder. So if you look at the bottom section there, if you don't have a tremor at presentation, you're actually unlikely to develop a tremor. And with the most common presentation of Parkinson's disease, people will have a rest tremor of one hand. There's no predilection for one hand or the other, or for dominant or non-dominant hand. And in the arm in which the hand is shaking, often there's an impairment of the speed of movement and the dexterity, and some cogwheeling rigidity about the wrist and elbow and shoulder. One thing I would comment about this, tremor is a very visible sign of a disturbance. And so the people who develop rest tremor of one limb, for example, very commonly get diagnosis of idiopathic Parkinson's disease established quickly, within a few months of onset of the tremor. But the individuals that do not have tremor, who are just slowing down and getting a little postural change, and feel stiffness in the neck and back, and notice their handwriting is getting smaller and shakier, and they're told by the spouse that their voice is getting weaker and they need to speak up, those kind of things. They will often go, up to several years before, with worsening disorder, and sometimes even substantial disability from Parkinson's disease before the diagnosis is established. I've had a number of them tell me, I just thought I was getting older. They have some other health problem to which it's been attributed. But anyway, tremor is not present in that group, and it delays diagnosis. It has been hard to identify the exact origin of tremor, and with the techniques we've had available to study tremor. But why should it be present as initial symptom in 2/3 of the people with idiopathic Parkinson's disease? The answer to that is not certain, but we do have some insights. Now, this slide I've titled it Preclinical Stage, but I will then mention that the movement disorder that I've been describing is due to the loss of dopamine-producing nerve cells in a structure called the Substantia Nigra, or black substance, that is in the midbrain. That's the upper part of the brainstem. The brain is connected to the spinal cord by the brainstem, so pathways from the brain that go down to the spinal cord that control muscles in the body pass through the brainstem. Pathways that carry feeling from the body come up through the brainstem to the brain to be processed. And dopamine-producing nerve cells of the Substantia Nigra send their axons, that's a long process on the nerve cells, into structures at the base of the brain, between the hemispheres and the brainstem, that are called the basal ganglia. And they deliver dopamine to the basal ganglia and modify movement, so that when the basal ganglia become deficient in dopamine, then Parkinsonism develops. Now, at the time that Parkinsonism develops, the first signs and symptoms, the individual with a mild tremor and a little impaired handwriting and a little bit of stiffness, maybe that arm doesn't swing when he walks like the other one does, have already lost 60 to 80% of the nerve cells in the substantia nigra on the affected side. One of the features of idiopathic Parkinson's disease that distinguishes it from related disorders is that there's often asymmetry. One side's more affected than the other in people with Parkinson's disease. That's seldom the case with other causes. Now, there is degeneration and loss of nerve cells in the opposite substantia nigra, and that will become symptomatic in the future for those individuals. But at the time of diagnosis, 60 to 80% of substantia nigra neurons are gone from the symptomatic side. By the way, it's the opposite substantia nigra that modifies movement. How many nerve cells in each substantia nigra? I'm expecting a correct answer. You people come to this education series over and over. Well, the best estimate is that in the healthy, mature brain, there are only about 350,000 dopamine-producing nerve cells in the substantia nigra on each side. Now, that is supposedly 7 to 8 billion nerve cells in the brain. So the number of dopamine-producing, or the percentage of dopamine-producing nerve cells compared to the total number of nerve cells in the brain is minute. It's a fraction of a percent. So if symptoms begin when you've lost 60 to 80% of the nerve cells, then you've lost 200,000 at least of the 350,000 nerve cells that are making dopamine for that side. And the best estimate is that when symptoms begin, the dopamine levels in the basal ganglia are about 40% lower than normal. Now, the question I ask about, why is tremor a common manifestation? The substantia nigra even is a kind of complexly organized process, so that the bulk of substantia nigra neurons are involved in functions in the upper limbs. And it is likely that the most vulnerable substantia nigra neurons to the damage that occurs in Parkinson's disease occur in an area of the nucleus, or which are the loss of which produces the tremor. So nerve cells controlling arm movements that, when damaged, lead to tremor are likely the most vulnerable dopamine-producing nerve cells in the substantia nigra. So that's why tremor is commonly present, and why a third of individuals have no tremor is a curious and unexplained phenomenon so far. Please. Thank you. About 10 years ago, I got to hear a presentation by the head of the Center for Neurodegenerative Diseases at the University of British Columbia. That's in Vancouver. And it is a center for clinical treatment.
Receiving content now, seeing blue screen. and we stop thermal content.
There we
You
go.
dropped me. Hang on, I'll try it again.
Okay, it says we're going to get content now, and blue screen.
And then it does me.
Hey, it doesn't sound like a fire alarm. I think we're safe at least. What's going on?
I think it's coming out of NASA.
NASA? Okay. Good. Well, then we won't worry about it. I don't need to take any action here.
No, you're good.
Okay. And so there's, I'm sorry, a large percentage of the people with Parkinson's disease and other movement disorders in British Columbia are treated there, so there's a large patient population for research studies. And the Canadian government has funded the bulk of its research studies in neurodegenerative diseases at the University of Toronto and at the University of British Columbia. And at the time, they had just completed studies of people with idiopathic Parkinson's disease, and they had some advanced MRI research studies, research techniques available. And one question they asked was, we know from autopsy studies, pathology material, that at the time of diagnosis, when symptoms have first developed of idiopathic Parkinson's disease, 60 to 80% of the neurons are gone from the symptomatic substantia nigra. So what is the rate of progression of the nerve cell loss in the substantia nigra at that point? Well, it turns out that it's about 10 to 15% per year. So that if you look at the time of diagnosis with mild Parkinsonism, signs of idiopathic Parkinson's disease, and you go 5 years down the line, that individual will have very few remaining dopamine-producing nerve cells in the substantia nigra opposite the side where the symptoms began. And if you extrapolate to the point at which nerve cell loss would have begun, if it proceeds at the same rate to lead to 60 to 80% neuronal loss at the time of diagnosis, then the loss of the nerve cells in the substantia nigra began 4 to 5 years before the onset of the movement disorder. Okay? So that 4 to 5 years then becomes a clear preclinical stage. There is Parkinson's disease pathology evolving in the brain, but the brain is not disturbed sufficiently to give rise to signs and symptoms for about 4 to 5 years. And then the amount of neuronal loss becomes apparent in symptom manifestations, and the neuronal loss continues. So that defines our understanding of the preclinical stage of Parkinson's disease to some extent, primarily to the motor manifestations of Parkinson's disease. Now, I also indicated that while there's loss of, this percentage of substantia nigra neurons at the time of diagnosis, there's relatively less. There's not a linear relationship to dopamine levels in the basal ganglia. The dopamine levels are relatively higher. So how does that happen? Again, the knowledge is incomplete, but there are two hypotheses for which there is substantial evidence. And the first is that there's some redundancy in basal ganglia nerve networks, so that when dopamine is deficient, normally some neurons that produce serotonin rather than dopamine can produce dopamine and deliver it to the basal ganglia. And secondly, the remaining dopamine-producing nerve cells increase their production of dopamine. So the nerve cells are revved up and hyped up. And we know that part of the damage to these nerve cells is happening.
Let me get rid of the audio. Got too many things going in the background. Driving myself crazy. Is that our phone ringing? Oh, nice. My battery's dead.
I'm glad to see other people have technical challenges with their information technology. Oh, as I was saying, we know that the loss of substantia nigra dopamine-producing nerve cells in part is driven by damage from the chemical processes that make dopamine. And yet, when nerve cell loss begins, remaining dopamine-producing nerve cells have to increase their production of dopamine, which would then tend to accelerate biochemical damage within those nerve cells. Yes, sir. Yes. There are several answers, and the next thing I wanted to mention pertaining to serotonin-producing nerve cells, there are multiple nerve networks that synthesize neurotransmitters like dopamine and serotonin and deliver them to the basal ganglia. The ones that are delivering dopamine originate in the substantia nigra. There are nerve cells in other structures within the brainstem that produce other neurotransmitters and deliver them to the basal ganglia, such as serotonin-producing nerve cells.
Hi, this is Brian.
Now, one thing I mentioned was that, say, 5 years after diagnosis of idiopathic Parkinson's disease, very few remaining dopamine-producing nerve cells in the substantia nigra opposite the symptomatic side, the side where symptoms began. So, how does L-DOPA continue to work? Isn't that a good question? The answer was not known for a long time. The answer, in part, is related to the multiple nerve networks that deliver neurotransmitters to the basal ganglia. And by the way, for anyone who doesn't know, dopamine deficiency in the brain cannot be treated by taking dopamine by mouth or even by injecting dopamine in the vein, because it doesn't cross out of the bloodstream into the tissues of the brain. However, there is a chemical precursor for dopamine called L-DOPA that, when taken by mouth, is absorbed into the bloodstream, crosses into the brain, and chemical processes within nerve cells in the brain convert it to dopamine. And those nerve cell processes exist in dopamine and serotonin. The chemical processes exist in dopamine-producing nerve cells and serotonin-producing nerve cells in the normal brain. So it turns out that the dopamine by serotonin-producing nerve cells that originate in other structures within the brainstem and deliver it to the basal ganglia. However, they don't deliver it with the same timing, and they don't deliver it in exactly the same places. So some of the erratic responses to L-DOPA that develop, motor fluctuations, dyskinesia, and so on, are driven by the fact that while we are delivering dopamine to the basal ganglia, we're not doing it with the same tempo, the same temporal characteristics, and we're not delivering it in exactly the same places. Now, if someone has mild symptoms in limb with Parkinson's disease, little tremor, little handwriting, not much arm swing, is it necessary to take medicine? Should medicine be prescribed for it? Well, we've had a number of trials looking at that question, and the trial design that's been utilized has been called the delayed start. And in that, patients are admitted to the trial with newly diagnosed Parkinson's disease, mild manifestations. And then they're randomized. Some get started on medication that's being used in the trial that improves signs and symptoms of Parkinson's disease, and get started right away, and some are asked to wait 6 months. And the trial goes on for a year to 2 years in the trials that we have so far. And then the medications are stopped. An appropriate interval for the effect of the medications on Parkinson's symptoms for the baseline Parkinsonism to reappear. That is, all treatment effect is gone through the washout period, and then their Parkinson's disease is restaged. Every trial, the L-DOPA trial, dopamine agonist trials, that's with Requip or ropinirole and Mirapex or pramipexole, and the Adagio trial, which was with Azilect, that's rasagiline. Every trial shows a benefit to early treatment, so that the individuals whose treatment is delayed have progression of disease to a greater extent than the individuals who were treated. So the answer is yes. In a scientific sense, it doesn't matter what they're treated with. All the treatments have a benefit, but the answer is yes. Now, if there is a stage prior to onset of overt symptoms and signs of Parkinson's disease in which there is nerve cell degeneration, in other words, a preclinical phase of disease, what we need to identify is some type of biomarker. Can we make a scan of the brain, do a blood test, test spinal fluid, and find the individual who is at high risk for developing overt Parkinson's disease in the short term? Well, the answer to the process so far has been that we don't have a satisfactory biomarker that clearly distinguishes people at risk from some people who have very low risk for development of Parkinson's disease in the short term. Blood testing has not been reliable. Spinal fluid testing can be highly suggestive, because if you're making less dopamine in the brain, then you're metabolizing and turning it over chemically less, and you have a lower level of metabolites of dopamine in the spinal fluid. But there is still an overlap with some normal individuals, so that doesn't clearly distinguish the preclinical phase. Neuroimaging, in particular with a procedure recently approved by Medicare for routine clinical services to help physicians distinguish a condition called essential tremor from people with a tremor that's a manifestation of Parkinson's disease. That's called the DAT scan. Is available, and it is approved and used only for that specific circumstance at the moment to distinguish the cause for tremor. But it is likely that the abnormalities that the DAT scan is detecting in early Parkinson's disease would be present to some extent in a preclinical stage. However, that has not been quantified or studied thoroughly. That study process is just beginning now. And what would we do if we found an individual who, by a biomarker, seems to be at high risk for development of Parkinson's disease. Well, perhaps use rasagiline or one of these other symptomatic medications because of the demonstrated benefit in people who already have mild Parkinson's disease, but that's not been proven either. Now, what might be some of the manifestations of Parkinson's disease in a preclinical phase? I'll go through these quickly. I got the 5-minute sign a minute ago, but the one that is most specific for development of Parkinson's disease is the REM behavioral disorder. And I will talk about each of these individually, but also certain psychiatric symptoms, chiefly anxiety or depression or both, occur. Constipation is very prevalent in a preclinical phase of Parkinson's disease. Impairment or loss of the sense of smell. Anosmia is loss of the sense. Osmia reduction is common and may occur for decades before the onset of clinical symptoms. So when we talk about the preclinical phase of Parkinson's disease, what I told you about the loss of Substantia Nigra dopamine-producing nerve cells has to do with the risk for development of the movement disorder. But it's likely that an underlying degenerative process is present in those individuals for many years longer. And then there is a group of dopamine nerves in the retinas, and those nerve cells decline in a preclinical stage of Parkinson's disease. Now, the REM sleep behavioral disorder, REM sleep is a rapid eye movement sleep. It's the dream phase of sleep when only our eye and respiratory muscles are active, and there's a block of the outflow into the spinal cord in pathways that move the body. And so normally we're paralyzed apart from respiratory muscles and eye muscles during the dream phase of sleep. And there's some evidence that in this phase of sleep, the brain is rehearsing nerve networks and maintaining nerve networks and connections between nerve cells by a lot of activity. With the REM sleep behavioral disorder, however, muscles that are normally paralyzed become active, and so these individuals in a dream phase of sleep shout, flail, kick, hit the nightstand, jump up and run away from the bear into the wall, kick the soccer ball and kick the door frame, or punch the wife. And this disorder actually very often shows up, is first diagnosed in emergency departments at 5 o'clock in the morning because somebody comes in with a head injury, or wife's gotten punched, or got a broken wrist. And then males are more frequently affected. There's a gender predilection for REM sleep behavioral disorder. And an individual who develops this has a 40% lifetime risk of development of Parkinson's disease or a related disorder, PSP, MSA, and so on. It's not specific for Parkinson's disease, but it is specific for this group of disorders. Loss of sense of smell. Our smell receptors are in the upper nasopharynx, and nerves go through the very thin base of the skull in the front part of the base of the skull overlying the eyes. That's called the cribriform plate, and form the olfactory nerves. And the olfactory nerve on each side goes into that temporal lobe. Some people with seizures that originate in the temporal lobe have an abnormal smell as an aura or a manifestation of the seizure they experience, because that's where sense of smell is processed in the brain. And deficiency of the sense of smell can antedate Parkinson's disease by decades. However, can also antedate the development of Alzheimer's disease and other neurodegenerative disorders by a long time as well. So it's probably a somewhat nonspecific marker of neurodegeneration. However, the majority of the olfactory nerves are dopamine-producing nerve cells. Another sign of dopamine neuron degeneration. Anxiety and depression, about 30% of patients who develop Parkinson's disease have been diagnosed and treated. So the symptoms have been severe enough to get into treatment. The response may not be quite as good in the individuals with Parkinson's disease, the response to typical treatments for anxiety and depression. However, when they develop Parkinson's disease and their dopamine deficiency is treated with medicines that augment dopamine functions in the brain, the neuropsychiatric symptoms don't tend to improve. So it's not purely a dopamine deficiency in the brain that's the cause. Individuals who have deep brain stimulation can develop severe depression. Suicide is actually a risk in that group of individuals. But the ones who had anxiety or depression prior to the development of Parkinsonism are not at higher risk for depression from DBS. So the presence of neuropsychiatric symptoms prior in a preclinical stage is not a contraindication to deep brain stimulation. The colon functions, that's the large intestine, functions to reabsorb fluid and electrolytes from the intestinal contents. And in Parkinson's disease, there's a slower transit time of the intestinal contents, so the colon reabsorbs more fluid. The stool consistency changes, the stool frequency declines. And the group of nerve cells that stimulate the intestinal muscle function, it's called the myenteric plexus. Myo is muscle, enteric is intestinal system. These nerve cells are found to be significantly damaged at autopsy in people with advanced Parkinson's disease. And Lewy bodies, one of the characteristic pathological changes in the brain in Parkinson's disease, can also be found in those nerve cells. So it's another sign of neural degeneration and begins long before motor Parkinsonism develops. So Dr. Brock, a neuropathologist, came forward with the hypothesis that Parkinson's disease is a condition that begins in the lower brainstem, and he found the earliest changes in a structure in the medulla, that's the lowest part of the brainstem before the brainstem exits the head and becomes the spinal cord. The structure called the dorsal motor nucleus of the vagus nerve. Vagus nerve is a nerve that carries sensation from the abdomen and chest to the brain and stimulates certain activities, controls the heart rate, stimulates intestinal muscle function, stimulates acid secretion in the stomach, and so on. The dorsal motor nucleus of the vagus is the first place where degenerative changes typical of Parkinson's disease develop. And then his hypothesis is that the process spreads from there higher in the brainstem to cause depression, REM sleep behavioral disorder, higher to the midbrain where the Substantia Nigra exists to cause the motor symptoms of Parkinson's disease, and ultimately to the hemispheres or the cortex of the hemispheres, which give rise to cognitive and neuropsychiatric impairment. He also, and that's not part of the Brock hypothesis, he also suggested that perhaps an infection comes from the body cavities and is carried in the vagus nerve into the brain and slowly progresses up the brain to give rise to the degenerative changes. There's no support for that, but however, everyone knows the story of H. pylori, the bacteria that causes ulcers in about half the cases of ulcers in the stomach or duodenum. And of course, if you'd told people, in the early 1980s that big cause of ulcers was an infection in the stomach lining, they would have said you were out of your mind. So we should keep an open mind on that. So the conclusions about what I've been describing to you about preclinical symptoms and these early clinical manifestations is that the neurodegeneration in idiopathic Parkinson's disease is not occurring exclusively in the Substantia Nigra or even in dopamine-producing nerve cells. And it occurs outside the milieu of the brain. So that any hypothesis that addresses the etiology of Parkinson's disease has to account for these kinds of observations. So thank you. I'm done. I've only run over a little bit, but we'll stay. We'll take questions as long as there's interest.
Thank you, Dr. Britt. Excellent. And I'm sure there are a lot of questions out there, and I'm sure people don't mind staying over a little bit. You had so much great information to share. I've got a few of my own, but I'm going to let the audience ask theirs first. So, as always, as we call on you, do turn on your microphones, and then when you're completed with your question, please turn your microphones back off. We appreciate that. So let's go to our colleagues in Anchorage, Alaska. And do you have any questions? Okay, we'll keep moving in interest of time. And before you ask your question, if you could tell us how many are in attendance, we appreciate it. Billings, Montana.
We have 3 in attendance, and we have no questions.
Thank you very much. Clarkston, Tri-State Memorial.
We have 10 in attendance and no questions. Thank you.
Thanks for joining us. Kootenai Medical Center.
Yes,
Any questions?
thank you.
Okay.
Yes.
Do you have a question?
Anybody have a question? Oh, I'm sorry, no questions.
Okay, thank you. No problem. Colville, Providence, or Mount Carmel, rather.
There are 4 of us here, and we have no questions. Thank you.
Thank you very much. Dayton General Hospital.
Yes, we are here, just the one person attending today, and the program was very interesting. I enjoyed it. Thank you.
Glad you could join us. Thank you very much. Syringa General in Grangeville, Idaho.
They don't have anybody coming.
Any questions, Syringa? Okay, we can always come back to you. Thank you. Kennewick General Hospital.
One of us, no questions.
All right, thanks for being there. Evergreen Healthcare in Kirkland.
4 of us here, and I guess no questions.
All right, thank you. Miles City, Montana.
I should turn off your stuff.
Any questions, Miles City?
We have no questions. We had 5 in attendance, and we really enjoyed the presentation. Thank you.
Excellent. Thank you very much. Moses Lake, Samaritan.
There are 2 of us today, and thank you very much for the presentation.
Okay, thank you. Mid-Valley Hospital in Omak.
Well, some may have left.
Yeah, that's true.
Sorry, Mid-Valley Hospital. Okay, we can always come back to you. Pendleton, Oregon, Public Library. Any questions?
We have 2 questions. I did. Is there a possibility to get the outline for the lecture today? And number 2, is there a medication in a generic form for bladder spasms that might interfere with what? With the treatment of Parkinson's?
Okay. I'm sure we can find a way to make the PowerPoint presentation available. And so you have an answer.
Cindy.
Okay, yeah, that will be done. Bladder spasms typically are treated with medicines that relax the wall of the bladder in the absence of any infection within the bladder. And there's no interaction with medication with Parkinson for the treatment of Parkinson's disease. However, for people who have Parkinson's disease with dementia, the bladder medicines, which do penetrate into the brain to some extent, can further impair memory and cognitive functions.
Read that.
We have 5.
Okay, thank you very much. Thanks for the question, too. Pullman Regional, any questions? Okay. And let's see, Walla Walla, Providence, St. Mary's.
2 people, no questions.
Okay. And if we missed you, we can always come back to you. But let's go to our local audience here at Spokane. Question? And Walt will bring around the microphone if you wait for that.
She looks like she has cerebral palsy instead of Parkinson's.
Hi. You talked about drug-induced Parkinsonism.
Oh, can you hear
is that
me now?
Is that a real disease? If you continue to take the drug that's causing it, is it going to go full-blown Parkinson's? Should it be treated? How do you deal with that? If you need to keep taking that medication that's causing the tremor or whatever the manifestation is.
Okay. And I assume everyone heard the question. And this comes up in other areas of medicine where medicine's causing a problem, but you still have to take the medicine. In terms of the treatment of psychosis, there are several very effective antipsychotic medications that do not block dopamine receptors. They're clozapine, and which is that's the generic for Clozaril, quetiapine, the generic for Seroquel. Those are the two preferred agents. And when people taking other antipsychotic medications or switch to those medications, usually achieve a good result with the medical outcome, and the drug-induced Parkinsonism goes away or becomes minimal. Sometimes after prolonged drug-induced Parkinsonism, there is persisting tremor. Drug-induced Parkinsonism can be very severe Parkinsonism with short step gait, balance difficulties, stiffness, no facial expression, small handwriting, pronounced rest tremor. So in general, it has to be treated and treated by medication withdrawal or shift to drugs that don't block dopamine receptors. Now, in terms of metoclopramide for certain gastrointestinal disorders like gastroparesis, where the muscle of the stomach just doesn't work, so the stomach is enlarged by several times its normal volume, and when things go into the stomach doesn't contract and propel them on into the intestine. Reglan's worked well for that, but there's no substitute for it. So individuals with drug-induced Parkinsonism from Reglan or metoclopramide treatment have to make a decision about what symptoms are the most troublesome to them.
Thank you for the question.
This is like taking boards. I have no idea what question is going to come up. It could be anything in the world.
You can answer this one. You mentioned dopamine production in the eyes and ears, and the first part of this is that dopamine production used for the neurotransmission within those areas? Is it for local use, or is it feeding the rest of the body? And does it relate to disturbances of the eye and ear?
Okay. There's, to my knowledge, no dopamine-producing nerve cell network within the ears, but certainly olfaction, smell sense, is in a large part, driven by dopamine-producing nerve cells. And the retina consists of layers of nerve cells, and one nerve cell layer is dopamine-producing and degenerates in people with Parkinson's disease, and that degeneration begins usually before the movement disorder develops. And it is likely that that is related in part to some of the visual problems that individuals with Parkinson's disease develop. That's a whole nother topic of great interest, I think, but they're both visual, perceptual, visual spatial, and visual processing abnormalities due to disturbance in visual processing area of the brain in people with Parkinson's disease, and visual abnormalities from the retinal disturbance from degeneration of those nerve cells. For a while, you remember when dopamine implants were being sought, Substantia Nigra from spontaneously aborted fetuses were taken and used for dopamine implants. For a while, there was an effort at culturing dopamine nerve cells produced in the retina as a source for dopamine implants, and that has continued, and that may actually be one of the sources of neural regeneration that will become available in the future for people with Parkinson's disease. Yes, sir.
Yes. Do you feel that the rate of neuron loss varies from person to person?
Does the rate of neuronal loss vary from person to person?
Yeah, and is there anything that can be done to slow that rate?
Right. Well, I think it very likely that the nerve networks we talked about are hit in different areas by different individuals based on differing manifestations of the disease at onset. Also, the clinical course, the rate of progression in Parkinson's disease is quite variable. Individuals who have tremor at presentation, remember that group of 2/3 of people, idiopathic Parkinson's disease, who have tremor at the time of presentation, have a slower rate of progression in general of Parkinson's disease compared to individuals who have no tremor. However, the individuals who present with no tremor generally have an older age at onset. So it's not certain that tremor is the only factor there. What we know at the moment about altering the rate of progression of disease is that antioxidant medications available to us probably have very little, if any, impact, and that the MAO-B inhibitors of rasagiline and selegiline are likely to have some benefit at an early phase of disease in slowing the rate of progression. That's based on Adagio and Tempo trials conducted. Also on the Datatop study back in the early 1990s.
Do you think exercise is a factor?
I think exercise is very important for functional outcome in the management of Parkinson's disease and in both the reduction of disability and sense of well-being for people affected by Parkinson's disease. It hasn't been shown to have a beneficial effect in altering the rate of progression of disease. However, we do know that movement therapies improve outcomes from stroke and brain trauma, other neurological disorders in which there is damage to the nervous system. So that has not been ruled out.
We've been dealing with Parkinson's at our household for some time now, and some of these issues, the symptoms and the treatments really haven't been our biggest concern. Our biggest concern with it has been the falling down. And if we could overcome that, we wouldn't even know we had Parkinson's at our house.
That's
I don't know whether exercise or there's some way to circumvent the falls.
Yes. Falls happen in Parkinson's disease in usually one of two circumstances. One is in a situation of advanced disease where there is postural instability and people just simply have poor balance. They're particularly prone to fall over backwards or to have toppling falls in which they just start going one direction and cannot correct the body position before they fall. The other, and we have no effective treatment for that. None of the medicines for any of the symptom manifestations of Parkinson's disease have helped that postural instability. So that is, assistive devices for gait when it's severe. They are limited to wheelchairs usually and have to transfer with assistance. Now, some individuals fall also when they have off-period motor fluctuations and their gait deteriorates. And so the treatment of off-period motor fluctuations with better medical treatment or with deep brain stimulation of the targets that are used now can be very helpful for falls that are happening due to motor fluctuations. The separate issue is, might there be different targets for deep brain stimulation that will help people with postural instability and gait disorders that lead to falls? And it was thought that we might have found a target, the pedunculopontine nucleus, which is even deeper in the brainstem than the substantia nigra, very hard to access by current surgical techniques, but feasible. And there was a lot of suggestion from animal models of Parkinsonism that deep brain stimulation there would be effective, but that has not panned out so far in the clinical trials, although that research is still ongoing.
Anybody else?
Anchorage, Alaska. Can you hear us?
Yes, Anchorage.
Yes. Are we on?
Yeah, go ahead.
We have several questions. First of all, numbness and tingling in hands is described as a side effect of the extended range Sinemet, but it's not listed as a side effect for regular Sinemet. And can you go over the mechanism of what's going on with that?
Okay. Actually, I think that information is probably not very relevant. I think it's unlikely that any formulation of a Sinemet, that's carbidopa-levodopa, causes disturbance in the sensory pathways within the nervous system. So I would discount that report that extended release Sinemet causes numbness and tingling. And for individuals that are having those symptoms, they need a thorough investigation of the causes. Which brings another thing to mind, which is sometimes some symptoms arise and, oh, it's your Parkinsonism or your medicine. We have to keep an open mind about, aging individuals who can have any variety of neurological problems develop as well.
Thank you. I have a second question. Is there any, can you give us any follow-up on the new Pro that's just been approved? Do you have much experience with that? We've just started it up here on some people, and for the last 3 weeks. Anything out on that, or you'd like to comment on?
I'll be glad to answer that. In fact, I'm going to be a speaker for UCB in giving presentations to physicians in this area about the use of the NuPro patch. And I'm going to the speakers meeting in Phoenix at the end of this week. So maybe if this question had come up next week, I'd be better prepared to answer it. But I had considerable experience with the NuPro patch before it was taken off the market, and have been using it since it's been released again. And the NuPro patch is a transdermal formulation of a dopamine agonist called rotigotine. And the chemical's in a solvent, and it's delivered slowly and steadily through the skin to be absorbed by the blood vessels deep to the skin, and gets into the circulation in that way. And one of the things it eliminates is the effect of a high blood level of either dopamine agonist available now, ropinirole or pramipexole, shortly after an oral dose when the majority of the drug is absorbed and appears in the bloodstream. And it is during those peaks in the blood level that individuals tend to have the most troublesome adverse effects from those medications of drowsiness and dizziness and fallen blood pressure. So the NuPro patch eliminates the peak-related adverse effects of the oral agonist therapy. Now, Mirapex, pramipexole, ropinirole also exist as extended-release oral formulations, Mirapex ER and Requip XL. But there is more of a peak-trough effect with both of those drugs than there is with the Nupro patch, so it's a smoother effect. Also, the Nupro patch is formulated so that if you leave it on, you'll have effective medication delivery for about 36 hours. It's recommended that you change it every 24 hours. But the extended-release formulations of both Miraprex and Requip don't quite make the 24 hours in the experience of my patients. And so people who have symptoms of from their dopamine therapies, either dopamine agonists or L-Dopa, wearing off, such as the person that's awakening at 3 or 4 or 5 o'clock in the morning with foot dystonia, painful spasms and abnormal posture in the foot and lower leg, or the individual who has very frequent motor fluctuations at the end of dose of Sinemet will get a better, smoother effect from the transdermal formulation of the dopamine agonist that's in Nupro than they can achieve from the oral dosing with the available other agonists. So I'm actually excited about its use. I think the cost differential, Nupro being a proprietary product and not a generic, compared to the oral generics available, is going to limit our use of Nupro to the very specific circumstance where only the extended release formulation can satisfactorily treat the particular symptoms, like nighttime foot dystonia. So we'll see how that comes along. Another aspect of the treatment of mild Parkinson's disease that I enjoyed with Nupro was it was originally released just for the treatment of mild Parkinson's disease. That labeling has been expanded. But we could have people start taking an Azilect or a Selegiline tablet every day and put on a patch, and they could adequately manage their symptoms with a patch and one pill dealt with once a day. Quite a different, circumstance from the kind of lifestyle modifications you have to take just to deal with your medicine when you have Parkinson's disease. So I'm very excited about its use. I think cost is going to be a limitation imposed by a lot of insurers, however.
One other question up in Anchorage, or comment. First of all, you're a very excellent presenter and gave a very good talk. But for people who are listening in all the different centers, I would highly recommend the Charlie Rose on PBS Brain series on Parkinson's. They have an hour discussion on the new etiologies of Parkinson's with prions and the history of it. I think most centers would find informative. Maybe you could make a comment if you've seen that. If you haven't, recommend it.
I have. What he's referred to is a novel concept that's come out of contemporary Parkinson's disease research that, like some other nervous system disease, Creutzfeldt-Jakob disease, and to a certain extent Alzheimer's disease, there is evidence that nerve cell damage is originating because some proteins produced normally in the nerve cells are folding incorrectly. So if you think of a protein as having a linear structure, but actually it will often be a sheet or a helix, whatever. If that protein folds abnormally, then its function is altered in the cells, and its metabolism in the cells is impaired because the way the cells turn over the protein and regenerate it becomes less effective. And so these abnormally folded proteins are called prions, and they're one of the causes of nerve cell degeneration in some neurodegenerative diseases, and there's recent evidence that is a factor in Parkinson's disease. It's also likely that this tendency for prion development in the brain is transmitted from cell to cell, which may account for the very long preclinical phase of Alzheimer's disease and for the progression of Parkinson's disease by the Brock hypothesis, beginning in the lower brainstem and progressing up the brain. So it's an exciting area of research, and all of the manifestations of that are not apparent. But that was the Charlie Rose brain series and devoted to Parkinson's disease.
I had a question.
Yes, please.
If you're taking selegiline, and then they recommend another medication to go with it for anxiety, and it comes up from the pharmacist that it's warning you not to take it. It's a stage 3.
He's really very good. It's the best.
I believe, yeah. I don't know if you heard the question, but the question is the individual's taking selegiline and another medication is ordered, for example, a medication for anxiety, and the pharmacy program that is run by the pharmacist when they dispense it, and then they give you these long sheets of paper with this minute writing on it that describes all of the potential side effects and interactions, or their program even kicks it out. And they say, we'll call your doctor, we're not going to fill this because there's an interaction and so on. I will give you some background about that. Selegiline, that was Eldepril years ago, now generic only Selegiline, a trade name for a sublingual formulation that's absorbed under the tongue, or absorbed in the mouth, is called Zelapar, and that's used a little bit in this country. And Azelact, that is Rasagiline, a Selegiline derivative. Those belong to a class of medicines called the MAO inhibitors, and MAO is an enzyme that exists in two forms. MAO type A exists in the liver and intestine, and it removes adrenaline from the body. There's some old psychiatric drugs used for the treatment of severe depression that are rarely used now, but they inhibited MAOA. So if you ingested something that caused your body to release adrenaline, it wouldn't be cleared from the system, and you would get booming high blood pressure, dangerously high blood pressure. Certain anesthetic agents will have that effect. So you had to be off your MAO inhibitor for a couple of weeks before you could have surgery. You were also advised not to eat moldy cheeses and other foodstuffs that have a substance called tyramine in them. Well, Selegiline and Rasagiline, or Azelact, inhibit MAO-B. That's the MAO that exists in the capillary network within the brain and within the tissues of the brain, in the doses that are prescribed for Parkinson's disease. So those drugs are selective MAO-B inhibitors in the doses that are used, and there is no potential for an adverse effect of severe high blood pressure with the medicine interactions that caused high blood pressure when MAOA inhibitors were present. However, these pharmacy programs don't necessarily distinguish between the MAOA and the MAOB inhibitors. And so they come out as some potential interaction there. The one that I see most often is the interaction with an SSRI medication. Prozac, Zoloft, Paxil, Lexapro, citalopram, Celexa, and so on. This is a group of medicines. And we actually have a huge experience indicating there's no concern. The caveat to that would be that in Europe, when Selegiline became available, it was thought that it might favorably impact aging in the nervous system. but a higher dose was needed. Instead of 10, then 20 milligrams a day. And at 20 milligrams a day, sledgeling is no longer a selective MAO-B inhibitor, but also inhibits MAO-A. And so if individuals exceed the prescribed dose of either sledgeling or rasagiline in this country, they're at risk for that kind of medicine interaction. So I think what I try to do is reassure the pharmacists that this individual is not exceeding the prescribed dose of the MAO-B inhibitor, and that there's no concern about it, and it's safe to fill the prescription. I've been dealing with that for about 20 years since sledgeling came available. Okay.
Going back to earlier,
Hello.
Alzheimer's situation, is there any connection with later Alzheimer's concussions at an earlier age, brain concussions?
There's been a lot of evidence accumulated from a variety of sources that brain trauma, relatively minor, repeated brain trauma, increases the risk for Alzheimer's. And there's even some science as to why that may be. At least one of the enzymes that kind of cleans up the tissues after brain injury tends to be deficient in people with late onset familial Alzheimer's disease. So it may be that individuals who are later going to develop Alzheimer's disease from brain trauma are genetically at risk for that. That's not clear. But certainly, we've had the experience of boxers, and now the concern by the NFL, about head trauma and inducing a risk for Alzheimer's disease. There's also, Parkinsonism that can result from repeated head trauma, and that's seen in boxers like Muhammad Ali. Tends to respond not as well to treatment.
Okay, well, in interest of time, I know there's lots of questions out there, and thank you very much for staying over. Great information. But in interest of that, first of all, I'd like to thank Dr. Britt for an excellent update for us. Thank you so much. And we'll look forward to
Hello.
So we're going to end questioning for right now. If you do have questions, even at the remote sites, feel free to email those to the Parkinson's Resource Center on our website. Real quick, next telehealth is Monday, October 8th, and it'll be hosted out of Seattle at Northwest Parkinson's. The speaker will be Dr. Eugene May, and ironically enough, when you talk about the dopamine in the eye, Dr. May is going to talk about vision challenges with Parkinson's. So as always, if you have suggestions, please let us know. And the DVD is always available by calling the PRC or going to the website. And one last thing, you'll notice the poster. Cindy, if you want to hold that up in the back. For those of you, especially locally or that may be in the Spokane area around October 5th, we have our annual fundraising event.
And
it'll be from 6 to 9.
I think they're still talking up here.
You can get tickets at the PRC.
Next time they'll have a chance for you probably.
At our site. So with that, thank you everybody. Thank you again, Dr. Britt.
Sounds like they're about done with their time frame they have. So
yeah, there you go. And you guys have a great day. Safe travel. Thank you very much.